PPT. Wednesdays research methodology as well as statistics. Thursdays Shalya. Friday RS and Bhaishijyam. Saturday Shalakya, and on Sundays Prasuti Sriroga. So this is how we have planned and scheduled our timetable. So for further details, you could contact Dr. Jazul, and very proficient and efficient faculties are taking class for you, and it will be like they'll be there for you for your doubt clearances, as well as these classes would be available to you as recordings also with PPT. So for any doubts or clarifications, you could always contact the faculties. So it will be a overall support from the set of faculties that we are providing till your exams. So hope you make maximum use of this facilities provided. So we can start the session. Today we have Dr. Hida with us. She's assistant professor in Challitantra in Coimbatore College. We welcome you, ma'am. We can start the session.
Hello, am I audible?
Yeah, doctor, you are audible.
Okay, fine. So coming to the introduction, almost 5% of population develop abdominal wall hernia. The common external hernias are inguinal in the about 73%, femoral 17%, umbilical 8.5%, and others covers the rare and rest of that. Then coming to the definition. So what is a hernia? It is an abnormal protrusion of a part or whole of a viscus through an abnormal opening in the wall of the cavity which contains it. So you understood when the patient will be complaining as a lump. So one part of a viscus or a whole of viscus is coming or protruding out of the wall. So that is called hernia. The term meaning is in Greek it means to bud, to protrude, offshoot. In Latin it is rupture. Next, coming to classification. So clinically, when the patient is coming to us, we have to first diagnose the case as a hernia. So first we will see how the lump will be. So once we are seeing the lump, we'll try to reduce it. That is, push back to the abdomen. So at that time, we can understand whether it is in the starting stages and all. It will be reducible hernia. Then next stage, it will be it won't due to any additions or the more contents are coming out. So becomes irreducible. Then further complication starts when it is getting obstructed. If either the contents are intestine or any viable parts which is having obstruction, so it becomes obstructed hernia. At this stage, it is more complicated because most of the additions and all it will result in either inflammation, then later on stage infection. So in that is the case we need an emergency surgery. So that is about obstructed hernia. Then coming to inflamed hernia, either the sac is formed because of the appendix or any Meckel's diverticulum, the content is Meckel's diverticulum, it will inflame. So that is inflamed hernia. Then strangulated hernia, in detail we will be learning in the last part of the class. Then second classification is congenital or acquired. So how the what is the etiology, that is will be discussed in the etiology. Third classification is what is the content of the hernia, or when the lump is found, what are the content which is coming out of the abdomen, or so what it can be. Either it can be omentum, so it is called omentocele. Then intestine, enterocele. Then urinary bladder, you know the term cyst is in case urinary any bladder, so bladder, urinary bladder, cystocele. Then it is called Litter's hernia if it is a content is Meckel's diverticulum. Then Miles hernia, then sliding hernia, Richter's hernia. So many names according to the content of the abdominal part in the sac. So these are the photos. You can see in the first two figures that is enterocele, that is intestine is the content. Then third is Litter's hernia in that Meckel's diverticulum. So Meckel diverticulum means a pouch-like outgrowth of the intestine. So the content is Litter's hernia. It is Meckel's diverticulum. Then you can see the U-shaped
Hello, ma'am. Hello, ma'am. Your mic is mute. Please unmute. Hello, ma'am.
Any problem? Am I audible?
And your mic was mute.
Sorry, from which slide? Can you just tell? Now it is fine?
Yeah, ma'am. You can share the screen.
Yeah, sure. Maybe one call came in between, so only. Sorry for that.
Oh, okay, ma'am.
So coming to the pathology, you can see the mainly so lump is found by it is a part is sac. Will be a sac, then there will be contents and a covering. So sac is mainly formed by pouch of the peritoneum, which comes out through the abdominal musculature. So that sac, you can see the picture. It is divided into four. That is mouth, through which the content is entering the sac. Then neck, which is the most constricted part. So it is this constriction is mainly resulting in the further complications like obstruction and all. So if the neck is small, it will get complicated. So neck, which is the most constricted part, and the body, which is the main portion where the contents will be lying, and in the tip part is the fundus. Next, coming to detailed description about inguinal hernia. So as you all know, mostly essay questions will be arriving only on this topic, that is inguinal hernia, difference between direct hernia, indirect hernia. Like that, so many questions will be arising. So you have to concentrate more on inguinal hernia. And inguinal hernia is a protrusion of a part of the abdomen through inguinal region of the abdominal wall. So where is the inguinal region? All will be knowing where the inguinal ligament, inguinal canal. We'll just brush up that points. So mainly two types are explained under inguinal hernia. So first we'll just brush up the anatomy. What is inguinal canal? It is a triangular slit. You can see in the picture above the inner half of the inguinal ligament. It has, the crease line between the abdomen and the thighs that forms the inguinal ligament. So between and the canal is between deep inguinal ring and superficial inguinal ring. It is almost 3.75 centimeter long and is directed downward and medially towards the pubic region. Then first deep inguinal ring. So deep inguinal ring is the starting portion. The opening in the fascia transversalis above the mid inguinal point. So when starting from the anterior superior iliac spine, if you draw a line to the pubic symphysis, in between that is the mid-inguinal point. Just 1.25 centimeter above the mid-inguinal point is the deep inguinal ring. It is almost oval in shape, long axis being vertical. Then superficial inguinal ring. So it starts in the deep inguinal ring and ends in the superficial inguinal ring. So it comes in the interval in the aponeurosis of the external oblique muscle. It is almost triangular in shape, and the other relations are just you have to understand that one. The boundaries of inguinal canal you have to just understand. Then contents mainly in male spermatic cord will be there, and the round ligament of uterus will be there in the inguinal canal in females. Next, coming to another important, it is very specifically, it is asked for 2 mark questions and all in some parts of the universities question papers. So we can see what is Hazelbeck's triangle. You can see the picture. It is a weak spot of the anterior abdominal wall through which the direct inguinal hernia protrudes. So you can see the borders. The medially it is a rectus abdominis muscle. Then laterally inferior epigastric. It is seen IEA. So it is inferior epigastric artery. Then below is the medial part of the inguinal ligament. So these three forms the borders of the triangle. So you can see a anterior superior iliac spine, that is ASIS, and toward pubic symphysis, the inguinal ligament is extending, and between that is the triangle, Hazelbeck's triangle. Next, coming to the types which are indirect or oblique inguinal hernia. In that, what happens is the abdominal contents or either the intestine or any omentum is entering into the deep inguinal ring and traverses the whole length of the inguinal canal and comes out through the superficial inguinal ring. So you just imagine the content is coming through the deep inguinal ring. It is entering the whole length of the inguinal canal and comes out through the superficial inguinal ring. And then what happens? So it is more common on the right side also. Mostly, 1/3 of the cases happens bilateral. Then in children, there is a more chance in right side, as it is dependent on the descent of the testis of which occur late. Then coming to the types. So once it is coming out of the superficial inguinal ring, the next stage it is coming to the entering the scrotum. So just if it is up to the limited to the inguinal canal and the processus vaginalis closed at the superficial inguinal ring, then it is called bubonocele. So it is confined to the inguinal canal. So it presents as an inguinal swelling, and most of the victims will be like young adults. So already it is having any problem with the processus vaginalis, which is a vestigial form. Then next comes the funicular. Funicular means what happens? It is just the content will be just fed separately from testis. That is just above the testis. It has stopped. So the processus vaginalis is closed just above the epididymis. So it is reaching up to there only. Then it is called a funicular. Then complete vaginal or scrotal hernia. So in that, what happens is the sac is continuous to tunica vaginalis. So the hernia descends down to the bottom, and the testis can be felt posterior to the hernia. So this is a schematic representation. This will be easy to understand. Indirect hernia can be divided as actually main, incomplete, and complete. In that incomplete, either it is just confined to the inguinal canal, or it has entered the scrotum, but it is not reached the bottom of the scrotum. In the other complete one, it has reached the bottom of the scrotum. So that is all about the indirect inguinal hernia. Then coming to direct inguinal hernia, protrudes to the posterior wall. So I have told it is coming directly from the abdomen. It is not going to the inguinal canal. You just understand like that. It is directly from the abdomen. It is protruding through the posterior wall of the inguinal canal, medial to the inferior epigastric vessel. So that is a main. That is also one differentiating feature. It is either medial to inferior epigastric or lateral to inferior epigastric. So that is through Hazelbeck's triangle. That is the relevance of Hazelbeck's triangle. That is, the direct hernia comes out through this triangle. Then, so it lies outside the spermatic cord, either behind or above or below the cord, and half the cases are bilateral. Then coming the differentiating features, you can just go through that. That indirect, it occurs at any stage, any age, commonly in young. Then ratio is 20 is to 1. Then bilateral is less. Then pyriform shape will be pyriform or oval in shape. As it is coming through the canal, it is the shape will be a pyriform shape. Then descends obliquely downwards and medially. Most of the time requires manual reduction, as it has to be pushed through the inguinal canal. So we have to manually reduce it. Then other test and all we will be discussing in previous next slides. Next, coming to direct, it is mostly because of the weakness of the muscle. So what happens in elderly people, it is common. Then females are mostly not affected. Then if it occurs also, it is mostly bilateral. It is called Malgagny bulges. Then spherical, mostly it is coming directly from the abdominal wall, so it is spherical. Then with a forward bulge, then automatically reduces. So as it is because of the muscle weakness, so what happens is, when lying down position, it is getting flattened, the muscles are relaxed, and it will manually no need of manual reduction. It might in the starting stage and all, lying down position itself, it will be reducing. Other tests we'll be explaining. Next, coming to symptoms. So the patient starting, obviously mild, there will be a mild pain, that is like a dragging or aching pain in the groin, discomfort. Then drag of a like mesentery pain may appear. Then lump according to the shape, like a pyriform or a oval, according to direct or indirect. Then coming to systemic symptoms, any obstruction is there, then intestinal obstruction, other symptoms like abdominal distension, vomiting, etc. will be there. Then because of other symptoms, like what resulted in hernia, like any other complications, like already I told in etiology, any chronic cough like bronchitis, bronchiectasis, then constipation, which we need to strain more. The abdominal muscles are acting for like straining. So in that BPH also, they have the hesitancy for your urine passage. So in that diseases where the straining of the abdominal muscle is there, we have to ask about those complaints. Then like in incisional hernia and all, any past history of like appendicectomy and all, we have to inquire about that. Next, coming to difference between enterocoel and omentocoel. Enterocoel means the intestine is the content, omentocoel means the omentum is the content. So enterocoel, what is enterocoel? In that, what happens is, there we can see, as intestine is the content, we can see visible peristalsis will be there in that lump. And the consistency will be elastic, like how we will be touching the intestinal part, elastic consistency will be there. And while we are reducing, comparatively, the first part is more difficult to reduce than the last part, which slips in. So once we started reducing, starting is a difficult, then once it is almost inserted, then it will go by itself. Then reduction, at that time we can see the gurgling noise of the abdominal gas, then may produce a resonant sound and may hear peristaltic. Here also auscultation, we can hear the peristaltic sound. Then in omentocoel peristalsis, we can't hear or see. Then the consistency will be duffy and granular consistency. The reduction is great, generally difficult. That is, as it is duffy nature, the first part goes in easily, but last part reasons to be reduced. So next, reduction. There is no gurgling sound. Next, coming to local examination. So first step, what will be the position? The first, we have to ask the patient to stand in the standing position only. First, we have to examine the part, and then ask the patient to lie down in the supine position, and how to do the reduction, everything we have to do in the lying position. So first, the lump should be examined in the standing position, then in supine position. Next, coming to position and extent. So in the up to the scrotum or just below, above that or below that, like in femoral hernia, it is below the inguinal ligament. So like that, we have to examine. Then to get above the swelling, that is mainly root of the scrotum is held and to try to reach above the swelling. That mostly in a, it seems like both the similarity will be there, like inguinoscrotal swellings. The purely scrotal swellings, we can identify by to get above the swelling. Then consistency, the duffy nature and the elastic nature, we have to then strangulate it. In strangulated hernia, there is a blood, even the blood flow is restricted, so there will be tense and tender. Then next, coming to impulse on cuffing. So what we have to do, after reducing the lump, a finger is placed on the superficial inguinal ring and the patient is asked to cuff. The root of the scrotum can be held, so that is the, then we can feel the impulse on cuffing. Then root of the scrotum can be held between the index finger and the thumb, and when the patient is cuffing, we can see the impulse on cuffing. It is usually absent in case of strangulated hernia, irreducible hernia, and obstructed hernia. So irreducibility, the how the patient is made to lie in supine position, and the indirect hernia, it reduces by itself. The taxis, the term is how the patient is made to sit lie in supine position with the thigh is flexed and to adduct and rotated internally. So in that position, we need to insert the reduce the contents back. So that is the reducible. Then coming to invagination test. So first we have to reduce, then after reducing a little finger or index finger, we can invaginate from the bottom of the scrotum. So like that, we have to reach the superficial inguinal ring, and then we have to rotate the finger like that, so that the we can feel the superficial inguinal ring at the tip of the inguinal ring. So if there is any indirect hernia, what happens? If the tip of the finger, we can get the impulse on cuff. So that one we can identify. If the impulse is felt in the tip of the finger, then it is indirect inguinal hernia. And if it is in the pulp, we are just rotating that towards the pulp of the pulp is rotating to medially. So what happens? A direct inguinal hernia, if it is there, means it will give the impulse there. So that is the invagination test. Next comes ring occlusion test. The deep inguinal ring is occluded ½ inch. So I told superficial inguinal ring is where the first chance. The second time we are occluding with the thumb. With the thumb, we are occluding the deep inguinal ring ½ inch above the mid inguinal point after reducing the hernia, and the patient is asked to cuff. What happens? Deep inguinal ring, the direct inguinal ring, if it is there, means it will bulge medial to the examining finger, but indirectly it cannot come out. So because it will be confined to the inguinal canal. So the ring occlusion will differentiate both hernias. Next, coming to Seaman's test. It is for 3 of it. That is femoral, direct, indirect. So the examiner places his index finger on the deep inguinal ring, then middle finger on the superficial inguinal ring, and ring finger over saphenous opening. The patient is asked to cuff or to hold the nose and blow. If the impulse is felt on the index finger, it is indirect hernia. The middle finger, it is direct hernia, and the ring finger, it is femoral hernia. I think it is clear. The picture is self-explanating. Next, coming to treatment. So treatment, what all in between, actually we need to do investigation. That just in that you all know USG is the main choice. In most of the USG, it will be clear. Then otherwise, if we need further investigation, we can go for MRI. Then in treatment, conservative treatment and operative treatment. In that, in some cases we can't do treatment, there is no treatment, or TRES. In some patient we can go for TRES. I will explain later. Then operative treatment, 3 other: herniotomy, hernography, and hernioplasty. So, in the no treatment, what happens is mostly because of any other general ill health or short life expectancy in elderly patients and who refuse to operation. In that case, we can use a TRESS or no treatment. Then in the TRESS, what happens is it is indicated who refuses for operation and unfit for anesthesia or patients of chronic bronchitis, VPH, etc. with the chronic other illness. Then contraindication. If it is irreducible, then patient are going for a sternus job hernia with undescended testes associated with huge hydrocele. Then patient is not intelligent enough to position the truss. So these are the contraindications. What is the method is in lying position after reducing the hernia completely. This truss should be used throughout the day except at night. Next, coming to the surgical management, that is, first is herniotomy. So you have to remember herniotomy, herniorrhaphy, and hernioplasty. So what is herniotomy? So what happens is sac, we are reducing the contents, and but the sac won't get reduced. So what we have to do? We have to remove that sac. The neck of the sac is, so before removing, what we'll do, transfixation. The ligation is put at the neck of the sac, and the rest of the portion is excised. So ligation and excision of the hernial sac. But there is no repair of the inguinal canal. Indication mainly in children and in young adults who have inguinal muscle is good, means we will do herniotomy only. Then coming to herniorrhaphy. So here what we'll do, first herniotomy will be done, then repair of the posterior wall of the inguinal canal by opposing the conjoint tendon to the inguinal ligament using non-absorbable material, that is proline or silk or a thick chromatized catgut. So that explanation is there, like basin is explanation, operation is there. So we'll be sharing more details of surgery and the clinical examination part to the PGs. So now I'll just explain what is hernio. This mainly what it is. That the explanation is not given. Just a simple explanation only I'm giving. That I'm not going too deep of the operation part. Then coming to the third one, hernioplasty. What do you mean by hernioplasty? So something we are adding, that is to strengthening of the posterior wall. We are mainly in the case of indirect inguinal hernia or abdominal wall is very like large hernia, and the weak abdominal wall is there. In that case, we need a mesh. So generally, proline mesh. We can see in the picture one like mesh or a net. There will be a net like a thing. It is called mesh, that is kept in between and sutured. So there are different types nowadays. It is done in laparoscopic procedure also. So transabdominal laparoscopic mesh repair is there, extraperitoneal, preperitoneal, like that. Different varieties are there. Just for UG exam point of view, no need of going to deep detail. In pages, we will be sharing the details later. So it will be under anesthesia, general anesthesia will be given. Then so that is all about you can go in the notes also. It is explained a little bit procedure. Then coming to the, so you can see the hernial sac is opened, then that part is removed, then mesh is sutured in there. Next, though we are doing all this surgery, even then recurrence is that so many complications like hematoma formation, chronic growing pain, other urogenital complaints are as complication. Even laparoscopic procedure also have got so many vascular injury, intra-abdominal gas embolism, then bowel perforation, bladder perforation, trocar complications. So much complications are there in laparoscopic also. But though it is a strangulated case and all, we need emergency surgery only. Next, coming to post-operative care, the patient should be placed in a flat in bed with the thighs somewhat flexed. In children, up to 4 to 5 hours, we can give a normal diet. Next, so that's all about the inguinal hernia. Next, coming to femoral hernia. So where is the femoral hernia occurs? It is in the femoral canal. The abdominal contents pass through the femoral ring and traverses the femoral canal and comes out through the saphenous opening. Saphenous opening, you'll be remembering that where the great saphenous vein is draining. That opening, saphenous opening, it will be coming as uh, a lump. So, what is the surgical anatomy? Anatomy of a femoral canal. It extends from the femoral ring above to the saphenous opening. So relations and all, you just go through it. So mostly the etiology is wide femoral canal and multiple pregnancy. This is actually common in females also. So multiple pregnancy maybe loosen the muscles there. That are all maybe the etiology. So what happens is through the femoral canal, hernial sac descends down vertically up to the saphenous opening and then escapes out into the loose areolar tissue to expand like a retort shape. That is a shape explained for femoral hernia, retort shape. Coming to clinical features, the females are more prone. Maybe the reason is multiparity. Then it presents as a swelling in the groin below and lateral to the pubic tubercle. That below is the main important point. That is below the inguinal ligament it occurs. The inguinal hernia occurs above the inguinal ligament. So there will be a swelling which is having impulse on coughing, reducibility, gurgle noise if during reduction, as the mostly the content is intestine only, and there will be a dragging pain. So next coming to the as I've told, because of the neck is small. What happens is obstruction and strangulations are more common in this femoral hernia, and it presents as intestinal obstruction that is painful, tender, inflamed, irreducible swelling without any impulse on coughing, and associated with the abdominal distension, vomiting, and features of toxicity. Differential diagnosis, obviously, the inguinal hernia will be in differential diagnosis, and any other abscess, then lymph node enlargements, lipoma, then femoral aneurysm, saphena varix. It is actually enlarged terminal portion of the long saphenous vein, saphena varix. It is also important point. Then hematoma in that femoral region. So all these can be considered as a differential diagnosis. Next, coming to treatment, herniorrhaphy is done mainly. Approach is either through inguinal canal or groin crease, incision below the inguinal ligament. Next, coming to umbilical hernia. Umbilical hernia, so umbilicus, the weak umbilical scar. The herniation is through weak umbilical scar and common in infants and children, mostly due to neonatal sepsis. So males are having majority of the cases. Then clinical features, it presents with a swelling in the umbilical region within first few months after birth. The size increases during crying, and the shape is hemispherical. So you can note all the different shapes in the difference in the lump shapes. Then defect can be felt with a finger during crying. Occasionally, it can go for irreducibility and obstruction also with pain, distension, and vomiting. Treatment, actually most of the cases it will reduce by itself, in within 2 years of age, it will go by itself. So we have just we can get support adhesive strapping across the abdomen. Then indication of surgery only if it is not going till like by 2 years it is persisting, it can be indication of surgery is there. So intra-umbilical curvilinear incision we will do, and the sac is identified, ligated by transfixation and closed by interrupted non-absorbable sutures. Next come para-umbilical. So near, what do you mean by para-umbilical? So just near the umbilicus. A protrusion or herniation through linea alba just above or below the umbilicus. It enlarges ovally and often attains a large size and sags downward. So neck will be very narrow, and the contents usually omentum, small intestine, or sometimes large intestine also. then it has got a tendency to go for additions, or the umbilical region is having that much fat content and all. So addition chances are more, and irreducibility and obstruction chances are more also. Predisposing factors, it is obesity, multiple pregnancies, flabby abdominal wall. Clinical features in this also, on the abdomen, maybe the multiparasity is also a cause. 5:1 ratio in female, a swelling which has a smooth surface, distinct edges, soft, resonant with a dragging pain, and impulse on cuffing, intestinal colic due to subacute intestinal obstruction, and eventually strangulation. Treatment is surgery. In that, specifically, Mayo's operation is explained. So that is actually a transverse elliptical incision, and then herniatomy is done. And afterwards, sometimes the strengthening of the floor is done with a defect in the rectus is cleared using interrupted non-absorbable sutures. Then sometimes if strangulation is there, the abdomen part or the bowel segment is resected. That portion is excised or resected, and anastomosis is done, followed by repair of the hernia. Mainly, there's one of the causes obesity. So obviously, post-operatively weight reduction, use of abdominal binders are required. Then sometimes complications are more prone. So infection and recurrence chances are there. So a drain is kept so that the infection or any fluid may not accumulate. Next, come to incisional hernia. It is also one important topic in case of in exam point of view, because incisional, we have seen so many cases, like mostly previously and all before LSCS, cesarean was done with the midline incision. So at that case, what happens is, because of the flabbiness of the abdomen, most of the cases the wound will be not healed properly, or any infection chances are there, or like that complications occurred usually. So almost aged people will be having that much develop chances of a risk of a chance in incisional hernia. So hernia through a weak abdominal scar, mostly previous surgery, either appendicectomy or any other abdominal surgeries, most commonly in old age and obese. So in this, first we have to ask what is the history, additional history to be collected. That is the detail of the surgery previously undergone. Duration, how long the incisional hernia has occurred is important. Then wound, history of any wound infection or emergency surgery or elective surgery, that tension sutures were put or not, history of pain, irreducibility, like that, all the precipitating factors like smoking, urinary, abdominal, respiratory, abdominal symptoms should be asked. Then these all are the main predisposing factors itself, that mostly what I told, midline incisions, vertical scar, lower abdominal scar, then injury to many muscles of nerves of the muscles, then scar of emergency surgeries, faulty technique of the closure, then poor nutritional status of the patient, presence of cough, any other complications like tuberculosis, jaundice, anemia, then any other malignancy, then smoking in the post-operative period, then intra-abdominal pressure increasing diseases like BPH, benign prostatic hyperplasia, straining, stricture urethra, like that. Any other reasons also will predispose this incisional hernia. So clinical feature will be swelling in a scar region. So previous surgery scar, we will feel a swelling or a lump formation. Then there will be pain, impulse on cuffing, gurgling noise. Often peristalsis also visible. Then we have to first, it should be an elective surgery. As we know, it is of not much complication. So we have to ask the patient for weight reduction, control obesity, then nutrition, because to help the wound healing, we have to adequate nutrition is needed. Then control of anemia, treatment of diabetes, hypertension, cardiac disease, any other reasons which is resulting in the abdominal pressure increase also we should be treating. Then we have to go for chest X-ray, mainly to any lung diseases, bronchitis, bronchiectasis, etc. We have to rule out, then mainly for this USG abdomen. So surgery, it is here the best is hernioplasty, that is mesh repair is the ideal one. In that also keel operation, double breasting of the rectus sheath, like that, layer by layer closure, like that. So many operation varieties are there. Then post-operatively, we have to give antibiotics, analgesics, nasogastric aspiration, abdominal binders, then prevention of paralytic ileus, control of obesity and other precipitating factors, stop with precipitating features like smoking and other associated causes. Then fluid management, we have to ampulation, we have to encourage walking after 2 3 days. Once the pain is reduced, we have to for the increased muscular movements, or we have to strengthen the muscles. So otherwise we are just lying in position for because of the pain, and means the muscles will not get strength. So early ambulation should be done. Next, coming to epigastric hernia. Epigastric hernia, where is epigastrium? So it occurs through a defect in the decussation of a fibers of linea alba. The center portion we have linea alba, anywhere between xiphoid process and umbilicus. So the center portion, midline, between the xiphoid process and umbilicus, anywhere the defect can occur. So what happens is, starting actually extraperitoneal fat is protruding through the defect, and as a fatty hernia, then it is producing like impulse on cuffing and all in the midline, upper midline. Then after some days, it gets enlarged and drags a pouch of peritoneum, presenting as a true epigastric hernia. So starting, it will be an extraperitoneal fat, then it is becoming it is dragging a pouch of peritoneum and presenting as a true epigastric hernia. These are some other types of hernia that no need in for UG level. You can go through it for 2 mark questions and all in PG levels and all. Sometimes in Viva and all, they will be asking the rare types of classification. It is explained in the notes. You can go through that. Then strangulated, that is important for both the UG and PGs. So we have to more concentrate on more on this, like mainly on this inguinal hernia and this strangulated hernia. It is an irreducible hernia with obstruction to blood flow. So obstruction is also to the intestine or the content of the sac, and there is venous congestion also. Venous supply is impaired. So that what happens, that swelling will be tense, tender, with no impulse on cuffing, and there will be features of intestinal obstruction. You can see the picture in that reddish color is that. So tender and irreducible without impulse on cuffing. Coming to pathology, what happens is the blood supply of the content of the hernia is seriously impaired, leading to last stage is gangrene. So that is actually not a gradual process. It will be occurring once the obstruction starts. It is a fast or rapid process. So mostly the bacteria infiltration will be there in like E. coli, anaerobic streptococci, and anaerobic bacteria are the Klebsiella, like that. Then coming to pathology. So what happens? So obviously there is irreducible, and there is obstruction. Initially, the venous return is impaired. Then there will be a congestion of the bowel. So that what happens? Further dilatation of the bowel, which become a purple color. Then fluid collects in the sac. Then eventually arterial blood supply also is impaired, and the bowel become dark brownish black colored with a flabby and fragile wall. So that friable wall, what happens? The bacteria began to migrate transserosely and multiply in the fluid of the sac. So that in the sac, the bacteria occurs, bacteria growth occurs, and because of that small perforations occurs at the site of the constriction ring, and it will burst and end up in peritonitis. So that is the complication. So once obstruction is suspected, emergency operation is the best choice. Then course of strangulation, narrow neck, adhesions, irreducibility, long time large hernias with adhesion. Clinical features of strangulated hernia. So what else? Sudden. So once the strangulation starts, there will be severe pain, sudden severe pain, persistent vomiting, constipation, and distension of the abdomen. And the hernia, the lump, how it will be? It will be very tense, extremely tender. They won't even allow us to touch, irreducible, and without any expansive impulse on coughing. There will be, once the peritonitis is beginning, there will be rebound tenderness, muscle guarding, all the symptoms of peritonitis, and dehydration, toxicity features, then electrolyte imbalance, abdominal distension with the guarding, muscle guarding, and rigidity, and oliguria because of dehydration. That fluid loss is there. So there will be these symptoms. In strangulated omentum, if the content is omentum, obstruction are not present. So they won't be seeing any obstruction symptoms like abdominal, but suddenly it will be going to gangrenous form. It becomes congested, edematous, and black in color, which secrete toxic fluid with a secondary bacterial infection. In investigation, first of all, we can see in the X-ray abdomen in erect posture itself shows multiple air fluid levels. Then we have to see for blood routine in that. Then along with that, serum electrolytes we need to check. There will be imbalance in the fluid electrolyte balance. Then blood urea and serum creatinine. Then total count will be increased. Leukocyte count will be increased. Then USG abdomen we can get the diagnosis, proper diagnosis. Then strangulation without obstruction. Mostly strangulation without obstruction means one is already told omentosil and in Richter's hernia. There will be no obstruction as there is no intestinal content. So without obstruction directly it will end up in strangulation. Then treatment of strangulated hernia. So emergency admission should be done. Then Ryer's tube aspiration, intravenous fluid to correct the dehydration and electrolyte balance, antibiotics, catheterization to maintain adequate. Already told, oliguria is one of the symptoms. So urine in output should be adequate. Then emergency surgery should be done. The sac is exposed and the fluid is sucked with the suction apparatus, and a basin is repair is done with the interrupted non-absorbable suture. The antibiotic IV fluid should be continued and the drain should be removed for after 4 to 5 days. And post-operative also complications because of more little bit of bacteria and all will be remaining. So infection leaked with the fistula and septicemia chances are more. So that is all about strangulated hernia. I have just given some of the names, which is rare only, but extra points are there. You can just refer. Some of the pictures are also given. Litters hernia already told. Sliding hernia, one part of the bowel only is there. Then pantaloons hernia, like that. So many names are there. So just go through that. So conclusion. Use your 5 fingers of the hand to complete all tests of hernia. First, thumb for deep ring occlusion test. The second is index, middle, and ring. So it is for Siemens test already explained. Then little finger for superficial ring, invagination test. Then rules of hernia examination: never forget to examine opposite side. We have to examine because most of the cases, bilateral cases will be there. Never forget to do per rectal examination. Any other complication or chance of septicemia like bleeding per rectum, we have to rule out. Then never forget to examine urethra. Any other reasons resulting in a hernia like urethral stricture or straining in BPH, like that, urethra and a rectal examination for prostate also we should be doing. Never forget to check abdominal muscles. We have to not only the lump, we have to see the muscles are strong or not. So that is all about hernia. Ma'am, shall we move to second topic? Give me. Anjana, doctor?
Yeah, ma'am, you can continue.
Okay, questions will be asked later.
Okay.
Okay, no problem. No, last we can continue. Hope it's visible. So coming to the second topic, Shudra Rogas. So actually, I'm dealing with only the shallow important topics related to Shudra Roga, because mostly the other diseases are not asked in our question paper. So mainly I have selected only 11 topics. So first of all, what is the definition of Shudra Roga? So as you all know, it is explained by Sushruta and Vagbada. So it is actually the definition is given by not Sushruta, it is given by Ashtanga Hridaya. In that Hindu commentary, it is explained that is Mandavega Mahavega Vyadayu Alparuju Arujaha Ye Mahandu Alpagascheva Shudra Rogastu Te Smrita. So it is from the Hindu commentary of Ashtanga Hridaya Uttarasthana. So what do you mean by that? Mandavega. So either it can be small episodes or small episodes, or the symptoms will be very less, or sometimes it will be severe episodes will be there. Then alparujo aruja, it can be either mild pain or even painless also. Ye mahandu alpagashe, it can be either big or deep rooted, or alpagam or little bit only. So both these are combined in this Shudra Roga. So it is called Shudra Roga. And the Shudra, the term meaning is given. Shudra Shaddaha Swalpa Adama Krura Paryaya Vaji. So three terms are used. Swalpa, Adama, Krura. What do you mean by Swalpa? So you can see Masha, Vyanga, Tilaka, Alaga, etc. So that are only small area is covered. Swalpa, the symptoms are very mild. Then Adama, Ruddha Gudda, Sharkara Arbuda, Kunaga. So ugly to look, or a dreadful nature in like ugly to look. Then Krura, Masurika, Vispodaga, Agni Rohinya. So it is very difficult or complicated to manage also in that condition. So these all comes under Shudra Roga. According to Sushruta, Shudratam Punaresham, in the commentary only it is told, Shudratam Punaresham, Hedu Lakshana Chikilsa Alpatvena. So because of the, it is small reasons only is that, like Vega with Vega Dharanam, only that much is enough for causing that much bigger disease. So Hedu, Lakshana, Chigilsa, all are mild only. Little bit only is there. So only Shudra, the name is given as Shudra. Adhyudiyatena. So as you know, there is no classification like Vada, Pitta, Kapha, Rakta and all. So Adhyudiyam, it is not only one is there. So that is explained as Shudra. This comes the definitions. It coming according to Sushruta Acharya 44, Ashtanga Hridaya, he has explained 36. Like Vagbada explained like Gardabi, Gandhamala, Prasupti, Irivelika, Koda, Utkoda and all, other than Sushruta. But Sushruta mentioned so many others like Padadari, Anushai, Indraluptam, like 11 explained extra by Sushruta. So like that combinations are there, you just go through that. Then coming to the types according to Sushruta. So I told 44. I no need to read all the names, I think. So most of these will come under Shalakya and Kaya Chikitsa. So you will be learning in that particular subjects. So first of all, one of the important topic is Pashana Gardava. In our actually parotitis, it is correlated to parotitis. Hanusandau Samudbudam Shofam Alparujam Stiram Pashana Gardavam Vidyat Balasa Pavanatmakam. So it is rising from Kapha and Vada. Balasa Pavanatmakam. And Hanusandhi, so root of the lower jaw, Hanusandhi, the swelling will be there and it will be slightly painful and immovable. So from alpam, slight alpa rujam, show a small swelling which is having alpa rujam, and stiram, it is immovable, that is explained as Pashana Gardavam. In modern, we can correlate it to parotitis. So coming to the treatment, Purvam Svedena Yojiyet Manashila. So first we have to do Swedanam, then Lepa with the Manashila, Haritala, Kushta and Devadaru. Then Pakwa, if it is Pakwa, Vedana should be done and Pranavat Chikitsa should be administered. Next coming to Chippa and kunakam. Nagamamsam adhishtaya pittam vadascha vedanam karodi daha pagaucha tam vyadim chippam adishet. So what is chippam? So mostly it is asked in exams. A difference between means both terms define chippa and kunaka. So either it is caused by vada and pitta and vada. It is aggravated and localized in the mamsa, of the nail. So mainly nail bed and produces what? Pain. Pain will be the burning. Pitta is there means obviously burning sensation. And in the pitta will encourage pus formation. So formation of the pus, these are the main. So pain because of vada, then burning sensation and pus formation of pitta. Like that you can learn. So that is about chippa. Then coming to kunaka. So like small difference is only there. In this there is actually a history of injury is told. Tadeva Akshada Rogakyam. That is actually name of Chippa and Upanaka. Both the names of the synonyms of Chippa. Then one more is Kunagam. That is Abhikhada Tradushto Yonako Ruksho Asidaha Khara Bhavetam Kunagam Vidyat Kulinamiti Samtidam. So Kulina or Kunaka. It is mainly history is due to any nail injured by either hitting or something fallen on the fingers like that. And so many would have experienced also. So what happens? It become rough, black and hard. Ruksham, Azidam, Kharam. All these points you should remember. So that is chippa means pus formation. Then kunaka means because of any trauma that portion is getting dried or a rough, black and hard. That is called kunaka or kulina, chippa, akshada or upanaka. Treatment is common for both the. Then what is sega with the ushnambu. Then in the case of chippa, we have to remove that pus area. Debridement is done. Then pus is drained and abhinga with the chakrathaila and sarja churnam. Sarja churna should be sprinkled over there. And kunagam. In kunagam also we should do the same thing, and there will be, you can use the thaila, which is medicated with madura gana, and which will help for the ropanam. Next, coming to kadaram. All will be familiar. Those who have gone for obviously in the cellular department, we could have seen at least one con Agni Karma treatment or excision of kadara. So that we have to see what is the reason. Mainly the pressure. Either the slippers are very hard or they are walking in rough surface. Like that history we can get. So Sharkaron Madide Pade Shadeva Kandakadibihi Medo Recton. Medo Rectanugesheva Dosherva Jayade Nrinam Sakila Kadino Grandir Nimna Matyonado Abiva Kola Matraha Sarup Shavi Jayade Kadaristusa. So what happens? The Nidana. What are the Nidana? By placing the feet on hard or rough stone, then by wound caused by any thorns, etc. By dosha aggravated together with the fat or like mamsa and medas and rekta. So by this, what happens? The meda and rekta will be aggravated along with doshas and forms a hardness or a granthi, hard like a bolt, like a nail, like a nail. Keelam, like a bolt, or sakilaha kadinas, hard like a keelam or nail. And in the mid, mostly the site will be in the middle or at the edge of the feet. And the size of a kola matram, the size of a kola, and having pain and exudation. So that is about kadara, or we can correlate to corn. And treatment is obviously excision and sneha dahana. We can do either using shalaga also, but the best thing explained by Acharya is sneha dahana, like thaila or sarpi or madhu we can use for dahana purpose. Next, mukha doshika. Sharmali Kandaka Prakya Kapha Marada Shonitehi Jayante Pidagayunam Vaktreya Mukadushika. So what is Mukadushika? Why I have told this is we are doing Jalokavajarnam in Mukadushika. So you can understand the Kapha Vada and Shonida aggravates that because of the Shonida involvement is that we can use Jalokavajarna in Mukadushika. The Pitaka resembling thorns of a Shalmali tree, Shalmali Vriksham, Shalmali Kandaka Prekhya. Then Kapha Maruda Shonidehi Jayande Pidaka Yuna means in the phase of a youth or a adolescent age there will be pimples. So we can correlate it to pimples. Then treatment is Vamanam, Yauvane Pidaka Cheva, Vishesha Chardanam. Chardanam is the indication. Then Lepanam, Vaja Rodra Saindavehi Sarshapanidam. So we can use a Lepa. Next is a Charmakila that we will be discussing along with Arshas. In text also it is explained as somewhere else in the Nidana it is explained. So the Charmakila, it is one among the Shudra Roga only. We can correlate it to either warts or even sentinel pile also. Charmakila we can correlate. Then Parivartika. Parivartika, it is one of the important Shudra Roga explained. Usually it is asked like a difference between Parivartika and Parikartika. To be noted, that is difference between Parikartika and Parivartika. So what do you mean by Parikartika? You have to know first. No, it is one among the anorectal disease, like it is pilonidal sinus in modern. It is Fisher inano. In Fisher inano, Parikartika. Fisher inano, anorectal disease. We will be dealing in detail about it. Then difference between Parivartika. So what is paraphimosis? So paraphimosis. Phimosis and paraphimosis also in modern we will be dealing in urogenital disorders later in classes related to urogenital disorders. So just write the topic as paraphimosis, Parivartika. Go through that. Mardana Pidanaachadi Tadeva Apyapikhadadaha Metracharmam Yeda Vayur Bajade Sarvadaschara Tada Vadopasrishtam tu Charmam Pradinivartade Maneradastat Poshischa Granthi Rupena Lampadi Savedanaha Sadahascha Pagamcha Vrajati Katpajit Maruda Agandu Sampudam Vidyatam Parivartikam Sakandu Kadina Chavi Cheva Sleshma Samuttida. So the doshas involved Marudajam, Agandujam or Kafajam. It has explained as three: Marudajam, Agandujam or Kafajam. If Kafajam, it will be causing Kandu or which will be Kadina. So three types it is explained. Nidana, Mardana, Pidanat, Abhikadat. So either due to kneading or Pidanam squeezing or Abhikadam injury, Vada will be getting aggravated and localized in the major charma. And what happens, the prepuce or the skin of the glans penis will be rolled over and it will be exposing the money. So it is called paraphimosis. The prepuce is everted back. It cannot be completely covered the glans penis. So in that condition, it is called paraphimosis. It is the exact correlation to Parivartika. So clinical features: Mane Radistat Koshesha Granthi Rupena Lampadi. So the money assumes the shape of a sac and hangs below the glans penis, and there will be pain and burning sensation, even formation of pus. So that is about Parivartika. Coming to the treatment, first we have to do
Ma'am, your sound is mute. Please unmute. Hello, ma'am.
Hello, ma'am. Yeah. Fine, no?
Yeah, now it's okay.